كل عام وانتم بخير ان شاء الله، ولكم المبارك ان شاء الله. نسال الله جل يكون من المقبولين ومن في رمضان ونعيد ان شاء الله علينا بالمبارك. شكرا ابو حسام على المقدمه. Now, the reason I choose the topic because as Dr. Abdullah just mentioned earlier, now in our practice we are seeing such a problem as more and more. 10 years ago, you count them in your hand, the number of cases you see with Fuch and Cataract throughout the year. But now I think the game changed big time. So this is now something that we need to address. I'll give a brief introduction, then I'll try to present 4 different scenarios we are going to face now if you want to deal with such cases. If you have a patient with corneal edema and no cataract, and if you have a patient with no corneal edema but cataract, and if you have both corneal edema and cataract, and if you have corneal edema with a scar plus minus cataract. This is 4 potential scenarios you are going to face if you deal with patient with Fuch and dystrophy and cataract. And also talk about the timing for surgical intervention, as well as the IOL calculation outcome and use premium IOLs and emerging treatment in such topic. Now, the definition, as we know, this is a disease affecting corneal endothelium, characterized by acceleration of the endothelial cell loss and the presence of the excrescences, which is the thickening of the desmoid membrane. It's usually bilateral with asymmetrical presentation. The prevalence, it was quite interesting. I thought it's much lower, but globally, we are talking about 4 to 11% of people who are above age 40 might be affected with the disease. If you go all the way to the east, in Japan, you talk about 3.5 to 4%. And if you go to the west all the way, you might see cases up to 11%. Unfortunately, we don't know in the Middle East what is the prevalence of Fuch endothelial dystrophy, but this disease usually affects people who are middle-aged, and signs and symptoms will appear after age 40. As we are going to be, our population will be aging, and the population who are above 60 will double in the coming few years, as well as above 50 and 40. I do expect that we are going to see more cases with Fuch endothelial dystrophy, and this is something that we need to be aware and how to manage. As I said before, previously we did not pay a lot of attention for the disease, but now I think we do. Diagnosis is merely as a clinical diagnosis. This is based on slit lamp examination. The clinician will be able to appreciate the presence of the corneal guttata or the excrescences of the corneal endothelium. And through the slit lamp test, we'll be able to say or label the patient as Fuch endothelial dystrophy or not. And now, as the disease progresses, it will be easier to diagnose when they develop corneal edema, and the signs usually could be endothelial stroma or desmoid faults, increase or stroma thickness, like in focal areas, clouding of the cornea, of the stroma mainly, and microcystic edema and epithelial bullae are other features. We use some diagnostic tests such as specular microscopy in order to help and confirm diagnosis and also help in monitoring. Specular microscopy is usually the most common device we use. We all aware about the finding that we expect to see when we do the specular microscopy in terms of the presence of the guttata, the excrescences, also the low endothelial cell count that decrease with time, as well as the polymycotism and the pleomorphism that we should appreciate when we look at the image we print after doing the specular microscopy. Confocal microscopy, to some extent, is similar to the specular. Maybe the image was a little bit clearer, and also it's going to outline the presence of the guttata as well as the endothelial cell count and the shape and the size of the endothelial cells. But on top of that, also it might also show if you have some stromal edema or epithelial changes, which we don't see with the specular microscopy. Are they enough now to diagnose? Now, the biggest challenge when we see patients with Fuch endothelial dystrophy is to monitor their progress. Because under the slit lamp, you may discover the presence of the guttata, then you might continue observing them, but you'll not be able to monitor the changes until they go into developing corneal edema, which is quite late at that time. Is there a way now to monitor? Different devices cannot usually give answers, especially specular microscopy. Now, more and more, Okay, we are using the tomography and made the four refractive maps. Recently, there are few features in the topography or the tomography map which was proven to be helpful in monitoring the progress of Fuchs endothelial dystrophy. Changes as outlined here that we can see. The first changes, normally, if you see the pachymetry map and the colored map of the pachymetry, you expect to see the multiple circle and the nice circles outlining the pachymetry measurement in different diameter, and it goes all the way away. Now, if you start to see losing that circular fashion or the oval fashion, which we call lose of the isobac, as you can see in this patient, early in the Fuchs endothelial dystrophy, he start to lose that circular pattern as he advanced in the other images, it was quite clear. The loss of the isobac started now to be used as an assign to monitor or to actually label the patient as if they're having subclinical edema and Fuchs endothelial dystrophy. The other sign that we see also the displacement of the thinnest point. Normally, in the right eye, the thinnest point will be displaced infratemporal within 1 millimeter. If the displacement goes in any quadrant within 1 millimeter other than infratemporal, or beyond 1 millimeter, it's going to go in any quadrant. This is a sign that the cornea started to be thicker locally, and that might be also alarming of the presence of the edema. Now, the other sign now, as the cornea becomes edematous, especially in the posterior surface, we do expect to see what we call an island elevated in the negative point. It's more like protrusion. Instead of that, as we see with the keratoconus, where we see an island with a positive elevation, we see an island with depression within the center of 4 millimeter. Now, what was interesting now, when they start to follow patient, using the three features, they found that if you have all three features, the chances that your cornea will progress to keratoplasty is almost 90%. This is about a 4 years follow-up. And if you have two features, it's almost like 48%. And if you have one feature, that will be 7%. Grading Fuchs endothelial dystrophy is mainly based on a clinical examination where we see patient under the slit lamp and we start to grade them from 0 to grade 5. They become modified using the same grading, but grade 0 is when you have no disease. The problem with the grading here is going to be difficult. Even yourself, if you grade the patient in one time, you come next time and you'll not be able to grade the same thing because it comes mainly in a subjective evaluation under the slit lamp. Currently, my clinic now start to suggest that if we want to classify patients with Fuchs, we either label them as Fuchs without edema or Fuchs with suspicious edema by using the tomography at the presence of the features that we just labeled, or the patient who has a definite keratoconus. The treatment eventually for corneal edema, as you all know, is keratoplasty. PKB was usually to be the gold standard for treatment, but now endothelial keratoplasty is gaining a lot of popularity, especially in the West. EK now is almost 90% of Fuchs disease who are in USA are treated with clinic specifically. In Europe and Australia, still desmosterone integrated endothelial keratoplasty is the procedure number 1. And I think it's just a matter of learning curve, as you see here in this curve here. Here where endemic started in 2004 and start to escalate as the years. Almost now about 40 to 50% of the procedure is done as endemic, while the basic is declining. I think most of the countries who are dealing with Fuchs dystrophy, they are going to follow the same curve after they pass the learning curve. Now, the question now is what to do when patient presented with different scenario. Corneal edema and clear lens. In this patient now, if we decide it's theoretically now that you are going to do keratoplasty specifically, endothelial keratoplasty. But we need to address a few points before we take our decision. Now, doing EK in patients who are phakic is going to be challenging. You will not be able to inject a lot of air in the anterior chamber. It's shallow, okay? And this is when it increases the regraft, the detachment of the graft. The other thing now, if you inject a sub-6, some people prefer to inject sub-6 to minimize the graft detachment. This is also going to carry the risk of posterior synechium in such patient. The presence of shallow anterior chamber and the trials of unfolding the graft will carry a risk of traumatizing the lens and creating the cataract. Also, in dealing with such patients, if they are young, we want to maintain their accommodation. On the other hand, we know now that the phaco technique now is advancing and it's becoming now in a way that is quite safe. So, if you decide to do endothelial keratoplasty in such patients, is it the right decision or not? And if you look at different studies now here, then 5 years follow-up for a patient who underwent endothelial keratoplasty, 60% developed cataract necessitating cataract surgery. Another 2 studies look at with very good follow-up. One is this is the longest 5 years. The other study is 3 years, and then in the other 2 studies, actually, the percentage actually up to 55% here and about 76% in the teaching who actually developed cataract. What they notice now that older age are more prone to develop cataract after endothelial keratoplasty. So, what will be the best approach now if you have an edema and clear lens? If you look at the literature, most of them actually moving toward, if the patient is young, below 50, but they just choose age 50, I think it's just an haphazard, it might be age 40 or it might be 45. Just the reason is to maintain or preserve accommodation, as well as the risk of developing cataract is lower in such patient, is to go and do endothelial keratoplasty alone. Now, if the patient is older, which means that he is at higher risk of developing cataract, either because of the patient, of the history of the surgeon, or because of the natural progression of cataract in aged people, or if the patient has a shallow anterior chamber, again, the definition of the shallow anterior chamber is not well defined, then you really need to counsel your patient that we have 3 options. Either we do the only endothelial keratoplasty and handle the cataract later on patient developed, or we do a combined procedure, or we do it as a staged procedure. So all the 3 options, and when I look at the literature, I found that there are different preferences among different surgeons based on the population he's handling, based on the patient expectation, based on their actual experience. The more they are experienced with endothelial keratoplasty, they will move and do the staged procedure, the EK only. The less they are actually comfortable, they will move to do the combined procedure. Now, what we are going to choose, this is something that would be interesting to see how is our practice is going to move in the future in handling patient who has edema but no cataract in our population. The second scenario, patient has no edema, clear cornea under the slit lamp, but does have cataract. So what are the things that you need to address when you see the situation? Now, first we need to ask about ourselves now. Who are prone to develop corneal decompensation after cataract surgery in such patient? The second question now, are all the visual symptoms patient presented with is related to cataract? Because now there are few papers actually address an issue that patient actually with good only, no corneal edema, even if they undergo cataract surgery alone, they end up being not satisfied or not happy with their vision. And this is related to that with corneal method itself, okay, might induce visual changes and might affect the vision of the patient remain. However, when we decide to do cataract in such patient, we need to do early cataract surgery is always preferred. You don't need to wait. The earlier, the easier, the softer, the less energy, the less endothelial cell loss. Now, soft shell technique is preferable. Phaco technique is best. Low flow irrigation. Experienced surgeon are better rather than patient or rather than surgeon training, and small capsulorhexis to make sure that the IOL is in the bag and just for future keratoplasty, we don't want an IOL to be moving forward. Now, until recently, I might practice when I see patient who is going to go for cataract and then to decide is I usually look at the following. I look at the endothelial cell count, and if it is less than 1,000, my decision is that maybe combined will be the option. The other one is if the endothelial cells between 1,000 to 1,500, and the pigment is more than 640 micron, then we go for combined. Now, such definition is under under investigation, because now we are seeing more and more evidence to support that following such guidelines is not the best practice. However, the biggest challenge in trying to get the endothelial count is that in 70% of patients who has complement mutant in the center, you cannot obtain spectrum microscopy image. And we see that in practice. So basically, you cannot count on the endothelial cell count as a guideline for your decision. You need to find a different way, because if you 72% of the patient with moderate mutant might not be, you will be able to determine the endothelial cell. This is going to be a challenge. Second thing also that you need to address now, that we see patient who has 1,500 or even 1,000 endothelial cells, they undergo cataract surgery and they do very well, and they last with a clean cornea for a few years. So this is also changing in the practice, or changing the concept that we do follow to treat our patient. We do agree to a certain extent that if you have endothelial cells between 400 to 600, this is when you're most likely to have corneal decompensation. Now, how about using the vectometry of 640 microns? Now, there are multiple studies showing that actually this is a very low sensitive dynamic measure to determine if the patient will progress or not. Because many people actually with normal cornea still will fall in that range. Many people actually will start with thin cornea. The cornea, they will swell and will never reach to 640. So still, they are going to be considered for you as a normal, but they are having corneal edema. So depending on the corneal decompensation per se is becoming less and less in order to determine your best decision. Back to the tomography and the feature that we have seen, two studies actually recently published, one for the 4 years follow-up and one with the 1 year. In the 4 years follow-up, they found that if you have all the three features in the tomography, the chances that you are actually develop corneal decompensation is almost 75%. The other study actually did find that if you have all the three features, then it's about 86% chance that you are going to develop corneal decompensation. This is without looking at the number of endothelial cells and without looking at the vectometry. The study actually tried to look actually at the image obtained from the confocal microscopy, looking at what we call the backscatter image of the confocal, where we can determine some hydration in the stroma, and they find also that can be a predictive factor. The biggest challenge with using the confocal microscopy image that there is no standard measurement, that there is a lot of variation in the interpretation of the image, so it will be really difficult and challenging to use as a guideline for the time being. So what would be now the best approach? No edema and a cataract. If there are no tomographic features of the edema and your endothelial cells is more than 1,000, then might be careful cataract surgery is going to be your option. In the other hand, if you have actually presence of the tomographic feature, or if your endothelial cells is measurable and it's below 1,000, plus minus in the vectometry still can be used as a guideline, then you're going to end up with doing either the combined or the stage procedure in such patient. Later on, we're going to come and also go in details which better is the combined or the stage procedure. Now, third scenario is corneal edema and cataract. Okay. Now this is we know now we are going to need that endothelial keratoplasty and we need cataract. Now the question is, do it combined or staged? And if you decide to do it staged, would you do phaco first before EK or the vice versa? Doing the combined procedure actually is quite popular among different studies where they have found actually similar outcome when they do the combined versus when they do DMIC or DASIC alone in pseudophakic patient. So then this is one positive actually sign that we can follow. Doing the combined procedure advantage that if we remove the crystalline lens, our endothelial keratoplasty will be easier. It's very cost effective because we're going to go through one surgery only instead of two surgeries. You limit risk of operative risk, easier for patient, more convenient with a faster recovery time. But the disadvantages during the procedure, actually there are two papers showing that endothelial cell loss more with combined versus EK alone. And the other thing that the refractive outcome, as now we are moving into an era where patients are becoming more conscious about their refractive outcome, the refractive is quite unpredictable, and you might end up with hyperopic shift because you will do your IOL calculation based on a keratometry reading taken from patient with edema. So most likely your keratometry reading will not be accurate in such patient. How about if you decide to do a stage and you do want to do EK, then you want to do phaco? What are the advantages? This will be the best to get for the refractive result because once you do the endothelial keratoplasty, you will resolve the edema, you will be able to do better IOL calculation, then you can go for phaco surgery. Both actually they make, okay, what's found to be very well attached after 2 months. Yeah, the risk of actually detaching the grafts if you want to do phaco is quite much less now and quite safe to do one phaco in such patient. What are the disadvantages? Still, the risk of endothelial cell loss will be more once because already it's high, about 30 to 40% in the first year after EK. If you add to that doing phaco, you expect now you're going to add another 10 or 15% induced by the phaco. Graft detachment might be still an issue, and also it's going to be challenging because if you want to do EK first, which means that patient will be phakic, we are also going to go through the challenges with the shallower AC, hard to unfold, the minimum air bubble you're going to use. However, if you decide to do that procedure, you need always to think about the future. So when you for phaco incision, you need to have a wall. So don't place your graft all the way to the temporal side. Make it a little bit nasal. Don't make it too large because you don't want your phaco to come in touch with the graft and detach it. If in the other way you want to do phaco first, then you want to do a EK patient. And I just want to address one issue. You want to do phaco first, then EK. The advantage again that you will remove the lens, so it will be easier to do EK later, and there will be less endothelial in comparison with the combined by doing such procedure. But what are the disadvantage? Cataract cells might be challenging because patient has edema, so cataract might not be smooth as if you do it if you do EK first. On the other hand, also, patient will present also with difficulties in the IOL calculation because they have the edema. You decided to do the phaco, you plan your IOL based on edema corneal. So if you go back and clear that edema, the refractive surprises might happen at that time. The third thing now, that there's no clear advantage of doing such a procedure over combined. There is advantage of doing EK then phaco, but there is no clear advantage of doing phaco then EK over the combined procedure. So in general, in such cases, then you end up on having either combined the procedure or a staged procedure as a cataract surgery before or cataract surgery after. I believe there is a lot of controversy in terms of what will be the best, but as I read more, I found that people in their early learning curve will always want to do the combined. As they master the EK better, they are going to move to do actually the stage where they prefer to do EK first. They will do EK first, then will do a phaco. Does EKB has a role? Definitely still has a role. If you have a corneal, if you have a stromal scar, then EK might not be the option. If you have a previous tube, ACIOL, aniridia, hyphakia, all such cases might be actually candidate for BKB rather than EK. How to handle now such cases? So if patient has Fuchs endothelial dystrophy edema, but no cataract, okay, in such patient, they prefer to do BKB because we know now actually, even though that cataract later might induce more endothelial cell loss, but we know that after BKB, refractive surprises is always a fact. And one way to correct it is by doing cataract surgery not to correct that. But if the patient actually has an edema and a cataract, then you have two options. One option is to do the combined as an ECC with the open sky and BKB, especially if it is hard cataract. Because you don't want to leave that hard cataract and do the BKB and come back again and do the cataract surgery. But on the other hand, if it is the soft cataract, okay, then your option will be to do the BKB. Then after suture removal, stability of the refraction, you will be able to take a better calculation. Then you might do a soft, gentle phaco emulsification or you can address the issue. During that time, I have seen patients where I operated, I removed the suture, but during the 1 year time I was waiting, the cataract became very hard. Then at that time, what will be your option? My option at that time is to do it as an extra cataract extraction after I do the suture very well. So in addressing patients with stromal and edema and cataract, if there's no cataract, we'll do PKB only. If there's a cataract, you will do combine if it's hard, or do it as a stage. PKB, then phaco if it is soft, but eventually if it's soft turns to be hard, then you do PKB followed by ECC. Time of surgery. Lesson learned, and this is something also that I came across in the literature, is that earlier better. If you have early sign of cataract, go and do it for the patient because it's going to be easier. Now, we see patient who has a corneal edema, and we negotiate with the patient about the timeline. This is something also that was learned from a lot of cases, which I really regret. Waiting a lot for patient to decide, you are going to lose it. There's potential. Some epithelial fibrosis can develop by waiting patient with a corneal edema. And also, the long-standing inflammation might be associated with cystoid macular edema and with the vascularization. So the advice, time of surgery, the area of the better, either for addressing the cataract or the corneal edema. IOL material in general, we don't advise for hydrophilic, specifically if you have a patient who is going to go under EK, because it's been actually observed that with air injection, the classification of the IOL in hydrophilic is quite high. IOL calculation, if you decide to do surgery after EK specifically, you always remember what we see in refractive surgery. In refractive surgery, the posterior corneal surface change. After EK, the posterior corneal surface change becomes steeper, will add a negative power. So what happened with our current keratometry measurement, we are overestimating the corneal power after EK. So if we do and field length the IOL, usually we end up with a hyperopic shift. The advice is always to target actual myopia after LASIK. This should be minus timing state from 0.8 to 1.25 and endemic 0.5 to 1 to provide to reach the dimetropia and overcome the hyperopic shift. The use of premium IOL, use of toric is very well advised, especially if you're going to do EK then phaco, not the combine, not the phaco then EK. And the reason why, if you do the EK later, you expect a lot of IOL rotation that's going to actually lose the benefit of using the toric IOL. So the best outcome in using toric, if it's EK done first, then we'll have a better measurement of the cylinder, then we can use the toric IOL. Multifocal IOLs being used also, again, for the same. They don't use it in combined or when they do phaco first, then EK. They will do it more in patient who has EK first. Then if we want to do phaco, they might use the multifocal IOL. Few cases being reported with the acceptable outcome, but still I think it's an area that we need to be cautious to address before we move and do it as a routine. Light adjustable IOLs is under investigation with a very promising result to overcome the refractive surprises. Managing the treatment now, hopefully we are not going to need, inshallah, keratoplasty in such cases. Now, there are 4 actually modalities of treatment in the line, what we call now desmin stripping without endothelial keratoplasty, the using of the ritual-associated kinase inhibitor, which is the ROCK inhibitors, and the synthetic desmin membrane transplant, and the injection of the cell therapy and gene therapy. And in this membrane stripping without endothelioplasty, I don't know if you can see here, but with the retroillumination, there's a central circle here. So the idea now, even in folks, most of the disease is central. You have a plenty of peripheral endothelial cells. They are healthy, they can migrate, but they cannot reach the center because they are blocked by the excrescences and the guttata in the center. So the idea by this that we are stripping the guttata, from the center, allowing the endothelium from the periphery to migrate and cover the cornea. This is a very brilliant idea, still under investigation. It still needs a lot of work. There are a few cases where they show actually 3 or 4 patients resolved and their edema resolved. The long-term outcome is not yet determined. The other modality of treatment, which is a medical treatment, is the ROCK inhibitors. Now, ROCK inhibitors in general, they believe that it has a role in terms of affecting endothelial cells in particular, and cell in general, in terms of differentiation, in terms of proliferation, in terms of migration. It's being used now in cardiovascular and cerebrovascular and pulmonary disease, but also now in vitro and in vivo with the corneal endothelial cells, showing that actually edema can resolve. This is a study where actually the only what they found encounter in their study, if you use the ROCK inhibitor in the cornea without moving the disease or the sick with that, it's hardly again the same concept that the endothelial cell will not migrate. So either through the transcorneal freezing, or either you combine the DSO, the disease stripping without endothelioplasty, with the ROCK inhibitor, where recently actually a paper published showing that about 22 patients out of 23, their edema resolved by using topical treatment. And actually there is a good percentage of the patient regressed after using stopped ROCK inhibitors. So this is an area which I think is promising for further studies to see the impact of using ROCK inhibitors specifically, plus minus DSO, in order to address the cornea. So this is in brief what I wanted to send as a message and what I learned from reading and from the practice, and I'll open the floor for discussion.